Rwanda, and welcome to this session, this breakout session that is focusing on opportunities in funding health and well-being for women. And if we look at the development frameworks for Africa, the role that gender parity plays cannot be overestimated. Right from the African Union, it recognizes that gender equality is a fundamental human right and an integral part of regional integration, economic growth, and social development. And the Agenda 2063 supports this. If you look at the UN SDGs, gender parity, gender issues are right there. In fact, there's its own SDG 5, with the ambition of achieving gender equality and empowering all women and girls. And these goals have been operational for a long time, since 2015, and yet in 2022, gender gaps remain a burning issue. According to the World Economic Forum, Global Gender Gap Report 2022, the report indicates that the gender parity is not recovering, and at the current rate of progress, it will take another 132 years to close the global gender gap. Narrowing in into health, if we look at the crises that have occurred, COVID, Ebola, women outcomes across health, socio-economic and productivity outcomes will suffer. And this risk of global gender parity will regress even further and further. And this is truer nowhere else than in Africa. So this afternoon, as we adopt a systems lens approach in tackling the development and human rights challenge, we are focusing on the crucial nature of women's health and wellness in addressing gender parity. Please allow me to welcome our panelists as they share their experiences and share more insights on this crucial topic. We'll have a moderated panel discussion, and then thereafter we'll open it up for you to interact with us as well. So it's my delight to welcome Nadia Kist, and Nadia is the Director of Africa Partnerships at Blood and Water. Please give a warm round of applause. Thank you so much. Next, I would like to introduce and warmly welcome Leah Chilenga Masamo. And Leah is the CEO of the Africa Sickle Cell Organization. Welcome, Leah. Thirdly, kindly welcome Nancy Ngao. She's the Global Affairs, Policy and Strategy Lead at Synergy. Please warmly welcome her as well. Finally, but not least, I'm glad to welcome Jacqueline Odiambo. And Jacqueline is the founder and executive director at Nyanam Widows Rising. So thank you so much for being here today and for lending your voices to this crucial discussion. And we'll dig right into the discussion. And I'll start with you, Nadia. According to many publications, I mean, we all know that despite the progress in gender equality, women's health, and generally health equity, since the Beijing conference 25 years ago, still lags behind. 800 women die every day giving birth from preventable conditions, and mostly in sub-Saharan Africa. If we go to gender-based violence, we know that almost 1 in 3 women are affected. And women and girls are also affected in COVID and other emergent public health challenges that have further widened the disparity that exists. So, Nadia, what are some of the priorities for women's health, and how can African stakeholders address gender inequality and promote health equity?
Yeah, that's a great question and not quite a simple question to answer. But I will certainly speak to it through the lens of how Bloodwater is responding to health disparities on the continent. For us, HIV and WASH have this intersection that responds to the health disparities that disproportionately affect women. Just to add to what you've already stated in those alarming statistics, 63% of new infections year over year with HIV on the continent is adolescent women and young girls. I mean, to say that we have been working in this space for 40 years and that number still is where it is means that something is not working. Something is not as effective as it needs to be. So when we talk about the health priorities of women, there's a lot of different issues that come to the fore. And truly, to respond effectively, it's to not respond through the lens of health in isolation of the woman as a whole. And one of the things that's really important to remember is that the female experience is non-monolithic. And so what that then requires, just to echo to what has already been stated a lot this morning, is to work at a micro-level investment with flexible philanthropic resources. That's putting resources in the hands of women-led organizations responding to the health disparities that they are experiencing community by community in a way that is truly owned and driven by the needs of the women that they are serving. That is really the only way that we can see that kind of catalytic change happen in the way that it needs to, and at the same time that there are significant and quite necessary bilateral, multilateral, and government investments that are happening at a broader national, multi-country level to strengthen health systems. The two together create a unique opportunity to have impact in a different way. So when you ask the question about what can philanthropic institutions like ourselves, what can we do to be more effective in responding to the needs of women, I would say categorically, we have an opportunity to resource the gaps that are not met by these larger mechanisms that are committed to strengthen the health infrastructure and the national health system. We can position our flexible resources in the places where those organizations, that category of funding is not designed to reach, and then really allowing the people who are the ones running the programs, doing the work, responding to the needs of women, to actually design and make decisions of where that funding needs to go. So it's our mandate, it's our call to action as philanthropic organizations to be flexible, to be nimble, and to make sure that the women are the ones that are making the decisions on what the priorities are and how best to respond to them.
Excellent. Excellent. Thank you so much for that and for really advocating for investment at a micro level. Jackie, if I may turn to you. You work in an area that is very dear to many of our hearts, working with widows and the organization that you founded, Nyanam, Widows Rising. Can you share from your experience what have been some of the barriers that you have experienced, and what measures can we take to improve women's statuses, especially health, socially, economically, and what implications would this then have on the health and gender parities?
Thank you for that question, Brenda. I think I first want to thank Musun and the conference organizers for inviting me, because oftentimes the experiences of widowed women don't feature and are not heard in these kinds of spaces, so I'm really grateful for that. In terms of barriers to women's health, there are very many, but I want to highlight three that I've observed in my work with widowed women. First, this is something that has already been talked about, but I want to give a practical example. So research, so investing in health research for women, and particularly investing in health research that is sensitive to the health needs of African women in our context. So, for example, we know that women generally suffer more from HIV/AIDS than men. So we do disaggregate the research by age, by sex. But as Nadia just said, women are not a monolithic group. And when you start comparing the experiences of widowed women to married women, to single never married women, to divorced women, you start seeing such different patterns. And when it comes to HIV, you start raising questions of what are the drivers for these differences in health outcomes. For example, widowed women have 2 to 6 times higher odds of being tested positive if you compare that to a married woman or a divorced woman. We know that women suffer gender-based violence, and according to Kenya Demographic Health Survey, widowed women are twice as likely to experience sexual violence and also physical violence. So if we can invest in research that is disaggregating these data, we can learn more about how the marginalization experiences, how different women go through these, and then learn how to invest to invest better with evidence. The second part I want to say is even how we are investing in health. So we know from public health that 80% of our population health is determined by social determinants for health, yet and only 20% is actually determined by healthcare or medical care. But in terms of our investments, our governments invest more in our medical care system than addressing the social determinants of health. And this issue also came up earlier in terms of for philanthropic organizations. There's been a culture of also looking for low-hanging fruits in terms of what to invest on. And so for us as an organization that is implementing the work, a low-hanging fruit can be a counseling session for a widow who came with grief and traumatized. So we can do a counseling session and report that. But in terms of the underlying causes, the question is, why did she even have trauma? And then she starts narrating issues of property disinheritance. And so you ask yourself, are we going to invest in land justice issues, or will we only continue investing in counseling services? So we need to invest more in structural drivers for women's health as one of the barriers, the gaps that we're not addressing. And the last one I wanted to say is even access to healthcare. So we, as governments, we're investing more. Our governments are investing more in medical care, but women, different groups of women don't have equal access or to this care when they need it. So poor women, widowed women, women with disability. In Kenya, for example, we don't have a health insurance in terms of like a national health insurance scheme that covers everyone. That's different for Rwanda. And so it means for a woman who is poor or widowed, you will seek care late because you are trying to balance the needs of your family. You have little resources, you're trying to balance putting food on the table. Will you go for cervical cancer screening first, or will you make sure your children are fed? And in that process, when you go to seek care, it's already late, and then you start incurring also catastrophic health expenditures. So I think those are three areas in terms of barriers to health. And when it comes to measures that we've taken as an organization, we are a restorative justice organization, and we implement integrated programs to address women's health issues. So we learned earlier on about let's not focus on issues and just pick one issue and run with it. We are dealing with the lives of people here. So we implement programs in health, in land justice, in livelihoods, agriculture, micro-business, and we really build on the strengths of these women. We start by asking you, what are you good at? And then we figure out how do we help make that more productive for you. And finally, as we do this, we are also investing in the leadership of these women. So in our organization, when we started in 2019, we were implementing things. Right now, it's the widows themselves who are implementing all of our trainings. We've taught them trauma healing. When new widows come, it's the widows themselves who are, again, going over to teach trauma healing. So really building on the strengths of the women. And what we've learned overall is that all of these different measures are contributing to the health of the women because they are addressing structural systemic issues.
Amazing. Thank you so much for highlighting the holistic woman, not just different portions of her that people have sliced and funded different, aspects. Leah, thank you so much. Your work at Africa Sickle Cell Organization is really renowned, but we still know that sickle cell disease is one of those very highly prevalent genetic diseases, more so in Africa, and millions, more than over 300,000 babies are born with sickle cell disease every year in Africa, and more than half of those die when they are very young. And yet, it's not getting the attention that it deserves. So, based on your experience, how can we speak about the need for strategic investments into diseases that are left behind, and particularly towards bridging that gender gap? And how can we all, philanthropists, funders, foundations, civil society organizations, collaborate to improve the well-being of women and children that are affected by these diseases, and men as well, actually?
Thank you for that question. Just a moment for the plenary. How many of you know sickle cell? Great, great. So I'm not a doctor, nor am I a philanthropist, but I was born and raised in a family where 3 of the 4 children have sickle cell, including myself. And I live in a community where 40% of the population have sickle cell. So in my 10 years of working on sickle cell, solving sickle cell, and my lifetime experience of sickle cell, I have seen very little change in terms of funding, prioritization, policy prioritization, and the intersectionalities that would allow opportunities for sickle cell to get funding, like WASH, HIV, and our big sisters, malaria. So, when we talk about the need, when I started this work, I started from a frustration because leaders and governments and doctors did not see the need because the data was lacking. Because if you don't see a person with sickle cell at my age, then you automatically classify that that is not a priority. And in African governments, priorities are dictated by money. So you have HIV, non-communicable diseases, NTDs, we have FGM, and you bring sickle cell to the table with no data. That is not going to be a priority. So I did a photographic narrative, a storytelling narrative to reach 10,003 people living with sickle cell in Kenya and Africa. I did not get to 10,003. I got to 300 because the situation on the ground was severe and dire. We still live in an Africa where sickle cell in the 21st century is still an omen and a curse, and some children born with sickle cell are killed. In houses where people like me live, houses you will find that not only it's one child, but multiple children because it's a genetic disease. So fathers abandon mothers financially and physically, disowning them. And in sub-Saharan Africa, where majority of disability and morbidities are experienced and majority of births are experienced, we only have maybe 3 countries who have policies around sickle cell. Where in an age where we are talking about primary health care, universal health coverage, the systems of primary health care do not integrate sickle cell. Okay? Where families, rural, local, very poor people living with sickle cell have to travel miles, spend money into private facilities because these conditions are not prioritized in our tertiary institutions. Adding salt into injury, we have to pay out-of-pocket expenses. I think 3 years ago, a health insurance agent told me, "Sister, your disease, this one, we don't do in Africa." Okay? So if that is not a need, let me remind you of a core quote. If we don't remember our history, we are doomed to repeat it. And I remind you the history of global health has colonial legacies, from colonial medicine to tropical medicine, where this medicine was developed for the colonialists, not for the locals. And that has been extrapolated to what we see now, because a disease like sickle cell that is genetically, ethnically, and factually African is not prioritized within its borders. I don't think there's a greater need for us to prioritize it than that. So for me, I don't know how much I'm doing with time, Brenda. How are we going to do this prioritization? How are we going to bridge the gender gap? Because most women and girls living with sickle cell or who have children with sickle cell are suffering in Africa. For over 100+ years, sickle cell has been in existence, but malaria has seen more progress. Cancer has seen more progress. Epilepsy has seen more progress. All the other diseases have seen more progress, but sickle cell is still orphan. Okay? So let me give a perspective from a person who has trials in fundraising. We have to look at funding strategically. We cannot extrapolate or transplant how funding is done in the West to solve African diseases and African problems. Because you know our culture, our norms, the way we do things is very different. We are Ubuntu. I am because we are. So why is our funding so strict and rigid that the people in the grassroots, marginalized communities and diseases do not get breathing room in this continent? And secondly, I want us to please consider investing in people living with these conditions, women and girls, because most of these grassroots problems, where there are no funders, especially for sickle cell, organizations come up because of necessity, and we manage however we will manage, and they are led by people like us with these conditions. But people like us are never given the power. We're only invited for photo ops to make agendas look pretty, but you're not given actual power. And when I mean actual power, I mean money. Deciding where this money is going and trusting us to know that our problems are our problems and this is how we are going to solve our problems so that the generation that we are going to birth will not face the same problem. And lastly, I want to encourage the African Philanthropy Forum. As much as we are bringing together philanthropists on the table, let us bring together those organizations that are grassroots-based, that can be able to have a light being shone on them and opportunity to get funding, empowerment, support, to be able to keep their doors open, to be able to sustain their lives, to be able to improve the social determinants of health within their communities for the next generation. Because where we have reached, if we are not addressing sickle cell, if we are not prioritizing sickle cell, there is no way we are going to attain health as a human right, all the sustainable development goals that we keep on singing, if we are not filling the holes of these diseases that are falling through the cracks. Thank you.
Thank you so much for that. I think a common thread that is running through is the fact that we need to invest in organizations that directly impact and are run by people living with those conditions. Thank you so much for that. Nancy, what new and emerging threats may impede a forward-looking agenda towards funding and executing ideas that continue to advance women's health and gender equalities?
Thank you for that question, Brenda. I'm very privileged to be here. It's my first time in Rwanda, a very beautiful country, very excited to be here. My first point, Jackie had touched on it. When it comes to women's health, we need to view all aspects of a woman's health, not just immediate access to some of these healthcare services, but particularly social determinants of health. And by looking at the surrounding or the environment of these women. And I want to specifically speak on sanitation. The work that we're doing at Sanaji, we are providing clean and safe sanitation for communities living in informal settlements in urban areas. So when you think of something like sanitation, the impediments to health when it comes to sanitation are various. So you think of diarrheal diseases, you think of loss in economic productivity due to poor health. And I'll give you statistics just to paint a picture. So globally, there are 4.2 billion people, billion with a B, that do not have access to basic sanitation. And basic sanitation, we're not talking about, you use a lever or a button and you don't know where the waste is going to. Basic, think of a pit latrine. So 4.2 billion people don't have access to clean and safe sanitation. And when you look at Kenya, we're talking about 10 million citizens. In Nairobi alone, 60% of the population does not have access to clean and safe sanitation. These numbers are staggering. We have 17,000 premature deaths of children under the age of 5, and also loss in economic productivity is up to $250 million. So $250 million every single year. So when we're thinking about health, we need to also think about some of the social determinants that are attached to health. And when we think about funding for some of these things like sanitation, for every dollar that is invested in sanitation, you get an ROI of $6. And that's in terms of loss for health investments and economic productivity. So even for funders and the government itself, investing in sanitation is a great kickback. So the ROIs are great. So one of the reasons why I'm focusing today on sanitation and women, connecting women's health and sanitation. When we think of women, we are the demographic that has the highest impact in terms of health issues that come from poor sanitation, because women, use sanitation facilities more than men, one. Two, in terms of menstrual health, we need a clean and safe environment for menstrual health. And secondly, security. If you think of like the areas that Sanaji works in informal settlements, if there are no toilets that are close to the home that you live in, you have to walk a distance. And for women, that's not safe. So they end up using flying toilets, which for those who don't know what flying toilets are, is in a polythene bag or a paper, and you literally throw it. So that's a flying toilet. Yeah. So women and sanitation are very key. Another threat to this funding for gender equality in health is the pilot syndrome. It's been talked about today a couple of times, is pilot after pilot after pilot. So where's the sustainability? Where's the longevity of some of these things? Innovations are there. They are there. When you think of innovations in health, they are existing particularly in this continent. So why can't this funding be directed towards scale? And there's a huge opportunity for philanthropy funding to go into scaling. Of course, the ideal situation would be public funding, that governments are equipped to be able to come up with these budget lines, ring fence for these specific innovations. But until we get there, how can we fill this gap? And that's where the philanthropy funding can come in and walk this journey with some of these innovators and implementers that are trying to get to their end goals. The next one is a collaborative approach. Again, I love when I come to conferences and everyone is just within theme. So working in silos. And I think private sector is very guilty of that, where we don't collaborate. Everyone is doing something. We don't need to reinvent the wheel. Everyone is doing something. Everyone is contributing towards this one thing. We need to come together and collaborate, particularly with government. We always say at Sanaji that we are complementing the efforts of the government. They are working towards their mandate and towards implementing some of these actions, and as private sector, we are coming in to bridge that gap. And the philanthropy funding as well comes in to support what government is doing in terms of investing in health. The last one is sound policies. Again, we had a whole session about creating an enabling environment for some of these innovations and implementing these actions. Policy is the backbone of any successful implementation project, anything. It's the backbone. So creating a very sound and friendly policy and regulatory environment, particularly for public-private partnerships, is key to ensure that we're able to bridge that gap. Thank you.
Thank you so much. Thank you so much, our dear panelists. Your insights have been very valuable. We'll turn to you for your questions and comments and responses. But before we do that, I know that we've just had lunch and all the blood may be going to the tummy. So can we just stand up and stretch? Want to give us a stretcher? No. Reach out and touch the ceiling if you can. Yeah. And touch the other as far as you can go. Yeah. Now touch your toes if you can get there. Okay, shake it off a little bit. Great. Yeah, thank you. How do you feel? All right, there should be mics that are going around the room. We'll take a couple of questions, and I'll start with, please introduce yourself, your name, and who you're directing the question to. The lady with the orange. Yes, thank you.
Thank you so much. My name is Marigiada Nicola. I'm with a foundation called IT Community Trust from Haiti. So one of the questions that I had for anybody on the panel, because we're talking about health, we're talking about social determinants of health, and we're talking about indigenous healing as well. And so I wanted to hear your thoughts around maybe not so much relying on what is philanthropy bringing us, but how do we engage in our natural healing resources in our communities that we also know worked, and that we can think about the integration of that in terms of our overall addressing of health concerns. And maybe then they would see, right, the possibility of what we can do in terms of our own healing as well.
Great, thank you. Let's take a couple of more questions, then we can answer them all at once. Yes, please. The gentleman at the front.
Good afternoon. My name is Lucky Palwan. I work with EPA's Nigeria Health Foundation. So mine is more of a comment, maybe just to support some of the conversation. One way that our society in Africa have tried to block the gender gap we're trying to close is through forced pregnancy. I said forced pregnancy, yes. So you are raped. I mean, gender-based violence is very common in our society. You are raped, and you are forced to carry the pregnancy. So for me, that is a double torture. Rape itself is an act of torture. The act of carrying the pregnancy to term against your wish is another torture. In Africa, most African countries have restrictive abortion laws. So you seldom can get access to abortion if you're raped. And even most of the philanthropy in Africa do not want to fund or associate with programs that support the right of women to have access to abortion. So no matter how and we all know there have been cases where families give their daughter to a wealthy man because he's got money with a promise to send the child to school. But what will he do? He gets the girl pregnant, knowing that with pregnancy she can't go to school. And that's the end of her career. And the potential that is locked in her may never be redeemed. So I'm happy that we'll be talking about that the woman is not in silo. So we need to look at it holistically and ensure that we're able to remove all the barriers that block the woman or a young girl from being able to fulfill her own inner self. I mean, I have a brilliant daughter, she's 12, and maths is her best subject. She's so passionate about it. So for whatever reason now, if somebody now says she get my daughter pregnant, and I think she would, because of that, she won't go to school. No way. So how do we ensure that we don't allow that to happen to a lot of women, a lot of girls, especially in the rural setting? I'm from Nigeria, so I can live with this. I know a lot of my colleagues who got pregnant because they were raped or because of, as they say, a mistake, and because of that, never went to school again because they couldn't have access to abortion. So it would be good for us now to begin to look at not just the symptoms, but also curing disease of gender-based violence and the others. Thank you.
Thank you so much. Another question? There was a hand up on this side of the room. Okay, let's respond to those two. One was about indigenous healing. How do we engage in our natural healing resources? Who would want to take that? You can? Yes, Leah.
Thank you for that question. Coming from Kenya, we also have not a challenge, but an opportunity. in the non-communicable disease space, where in rural communities, in any community in Africa, the first point of care is traditional herbalists, usually. Let's not lie to ourselves, right? So how do we, instead of sidelining them and keeping them away, bring them to the table to make sure that these traditional remedies are healthy, that they are safe, and they are quality? So in Kenya, what they're doing, they're creating a policy to include these traditional herbalists and alternative medicines to be able to be accredited so that they can be able to be included in healthcare regimens. And I want to specifically speak for sickle cell and other so-called local diseases. For sickle cell, you know, it came about because of malaria. Where there is malaria, there is sickle cell. And from many of you who come from sickle cell burdened countries know that certain herbal remedies support sickle cell. Moringa, cassavas, like very specific herbs, because they support the immune, they support our iron levels. So what we are doing through the Kenya Medical Research Institutes, we have brought in these herbalists or these traditional components that people use locally to support sickle cell and other diseases, so that they can be researched and be verified, so that they can be made into ways that they will no longer harm. Because when you take traditional supplements or medication without regulation, then it becomes a problem. So those are the ways we do not completely set them aside, we bring them to the table. I don't know if I've answered your question.
Yeah, I'd also like to contribute to that. That's a great question. So maybe just speaking from the angle of a funding partner, what I didn't say at the onset of the session today is that Bloodwater is a private philanthropic organization that partners exclusively with African-led, community-driven organizations that are responding to either HIV or WASH-related health disparities. And with that, we also invest in their institutional health, their people, their systems, their policies, so that they can be autonomous. And part of that autonomy is a marker of our success as a funding partner. And with autonomy is also this posture that from the onset, and again, just a call to action for other philanthropic organizations in the room, there's an attitude and there's a posture that we hold. And if we truly believe that communities are the rightful custodians of their development, if we truly, truly believe that they are the experts, their solutions are rightfully poised to meet the needs and end the drivers and the social determinants of health that we keep talking about, then it also means allowing resources to fund indigenous health, treatment solutions, strategies, whatever the demand is, that should be what is rightfully resourced. And something that we're also doing in tandem with that is we've created a community of practice called the Leader Collective. And it's a community of practice that exists to convene and amplify African leadership within our community of partners. And as of next year, we'll open it up for a wider membership. And the goal of that is to be able to allow organizations that are owning these solutions, that are seeing the evidence of impact in in more non-conventional strategies, that they have the space to document their learning and to push it out as a best practice that could be replicated in other spaces. So it's about, again, truly living the posture of letting partners, letting communities lead, and also giving them the voice and the platforms to showcase their innovation, to showcase their best practices and what is truly working to serve the communities that they support.
Thank you so much. Moving on to the second question about sexual reproductive health and rights. Jacqueline, do you want to take a stab at that?
Yes.
And then the rest of our panelists can chime in. Thank you.
Yeah, and quickly on the healing question, one of the things we are also doing at Nyanam is we have these forums with widows where we try to reclaim indigenous knowledge. So we've done it on agricultural practices, and now the widows are re-implementing like how to use sun drying for vegetables, and they dried vegetables that I actually traveled with to California, and for 6 months the vegetables were fresh and I was able to eat them. So, and then the other aspect also in terms of beauty. So we are trying to do like a soap making training with the widows, and we bring those who are herbalists to share about their knowledge about beauty traditionally and how to incorporate that in sort of like solutions that we have now. But on the question about forced pregnancy, rape, and access to abortion services, it's a whole process of so many things happening to a woman before she gets to needing abortion care. And I think as we've been talking about trying to address the structural issues, so we need to start from sort of what are the circumstances that are exposing these young girls to rape. And we know, for example, that young girls growing in poor houses where they don't have food or sanitary towels. Girls talk about going out to ask for, to have relationships with men or whatever, to be able to even have sanitary towels. So we need to implement more in those spaces where we are addressing factors that can prevent exposure to these kinds of incidences, such as rape. And then second one is, if rape occurs, what do we do? Oftentimes, as a young woman, you're blamed for what happened to you. There's nobody to listen to you. There is no good structure for accessing care. If you are to report, you have several people have to confirm that you're raped. In itself, it's also like my body is already being violated even more when I'm trying to have justice when rape happens. So we need to strengthen our policies and particularly enforcement of how we address issues of rape when they are reported, and that mechanism is from the health sector, but also the criminal justice system. And then finally, if a young woman is raped, our keynote speaker talked about bodily autonomy in the morning, and I think we need to prioritize that and be able to provide safe care for these young girls when they need it.
Jackie, just to add on what Jackie has spoken about, I can give a personal experience of an organization that I worked for previously that was trying to develop policy, working with the Kenyan government to ensure that school-going children had access to menstrual health products and sexual and reproductive health awareness. And what we did was a study to show that if school-going children had access to those two things, other things would follow. They'd be able to finish school, lower numbers of dropouts, lower pregnancies, lower teenage pregnancies, and lower contraction of STDs. So we did a study with 300 girls. So put them, just go with me, 300 girls into groups of 3, so 100, 100, 100. So 100 of them, we gave them menstrual health products and sexual and reproductive health awareness and education. The other group, just the menstrual health products. The last group, sexual and reproductive health awareness and education, and followed them from mid-primary, so around 10, until they completed their primary school education, so around 14, 15. And what we found was the group that we did give both the access to the products and the sexual and reproductive health awareness and education, 90% of them were able to finish primary school without contracting any STDs, no pregnancies, and they were able to finish school. So as Jackie has mentioned, we have to be able to create these systems that create a safe space for girls to be able to prevent rape and not having some of these safe spaces to nurture and grow. Thanks.
Thank you so much. We have a few minutes left for maybe one round of questions. Maybe as you're thinking about your question, I could ask Leah, We've talked about leadership and the importance of putting women at the forefront of policy and decision making, and as one of the potential pathways of achieving gender parity. Can you give us some of your experiences or share some of the lessons learned where that has been done across public, private, or social sectors? Yeah.
So this is an example that happened during COVID-19. So it's a story, so please bear with me, I tell a lot of stories. During COVID-19, I say COVID-19 was a plus and a minus. Minus in many aspects, plus because it brought a lot of funders, a lot of players on the table. So at the beginning stages of COVID-19, when all countries were going into lockdown and the communities, grassroots communities were also at a standstill, so no more meetings, no physical interactions, no access to medicine or clinics, we thought we would be on lockdown for like 3 weeks, 1 month tops, and we'll go back. So when 2 months passed, we started asking ourselves, so okay, what is not happening? Because our clinics are closed, there are no medicines on the counter, and there's no one who is giving us a solution on how this is going to be resolved. So as I was talking with my community and mobilized patients and women in the ground, I was like, what are we going to do? Because these conversations that are happening about COVID and access to care are happening virtually, and we don't have access to those virtual products or mobile networks. And we have 1 day a week where we don't have electricity. So how do we resolve this? So we actually reached out to first ladies. First ladies are within the different counties in our communities. First ladies are the wives of governors. Governors are the like small presidents of the small states within a country in Kenya. Yes, they decide the priorities. So we are like, how are we going to solve our problems? We want our clinics opened. We want medicines in our shelves. So these first ladies saw an opportunity to be able to bring us on the forefront where there were COVID-19 stakeholder partners, technical working groups that failed, absolutely failed to include the people on the ground who actually know what is happening. So these first ladies brought a couple of us into the decision-making tables, into these technical working groups. I was like, so now these are the people who can share the stories of what is actually happening on the ground. And within 3 weeks, we got the clinics opened, we got the medicines, because instead of them listening to the media, they listened to the people within those communities that are highly and disproportionately affected by COVID-19. So I think one of the most beautiful examples is these women leaders, these first ladies, even as Her Excellency Jeanette Kagame has done for Rwanda. I think we should also look at the local leaders, the local female leaders, as entry points of changing policy, of making great change, especially for those communities that are marginalized and not spoken of. Thank you.
Thank you so much. It's good to hear such positive examples. Nadia, can you share further examples from wherever that demonstrate building blocks and evidence-based strategies? I think we've kept going back to the need to invest in research, the use of data. So do you have any examples that are going to spur us into more investments into the lives of women and girls?
Yes. Whoops. Yeah, it's working. Okay. One of the very exciting things for anyone who worked in the HIV space during the COVID response was that Dr. Tony Fauci became a household name. And he was, to the HIV activist community, he was already our household name. And one of the things that he had brought now to the general public, the knowledge of the power that grassroots organizing had to effectively bring governments to their knees to respond to the HIV epidemic, first domestically and then globally. And I think that that, for me, is one of the most powerful evidences for action. That's a 40-year-old evidenced set of information that we are just now, post-COVID, harnessing on the kind of scale that we should have been doing from 40 years ago when we first were able to harness this information. So I would say, again, just going back to the call to action for us as a community of philanthropists, we are uniquely positioned to not just collaborate to have impact, but to coordinate. And I think that's really, really important. All of us in the room have different priorities, different types of organizations that we partner with. Could you imagine the impact if we coordinated better to see the cascade of funding that an organization can transition through the lifetime of their institutional health and longevity? I mean, talk about seeing organizations become fully self-sustaining and not dependent on any single funding partner. So I think if we truly, truly see the power that exists if we were to position resources in the right hands at the right level with flexibility and autonomy, and one thing that I haven't yet said, multi-year funding. Our partnerships have a minimum of 8, well, it's a full grant relationship up to 8 years. So from the first day of our partnership, we know when the end will be. And we can plan for that so that there are no unforeseen vacuums created in an institution. So if we could really harness the power of communities, and in the case of when we're talking about gender equality, when we're talking about putting women and girls at the forefront to bridge the gaps that exist, it means resourcing them, their ideas, their strategies, and their vision for change in the organizations that they're leading.
What a powerful call for action. Thank you so much. Jackie, our time is up. Last call to action, and then we'll come round as we end the session.
I'll mention, we know that women participate more in the health workforce in terms of healthcare delivery, and there's a group of women called community health workers. They have different tags in different settings. In Kenya, they're called community health volunteers, and these, majority of them are women. Most of them come and, of course, live in these low-resource communities. And the sad thing that happens, at least in Kenya, I know Rwanda has made some strategies in terms of formalizing their contribution into the healthcare system. But in Kenya, they're still considered informal. So they're not part of the formal healthcare system. They're not reimbursed yet. Their workload, every time you look at what they're expected to do, maternal health, child health, infectious diseases, right now even non-communicable diseases, going around homes, looking for those who have high blood pressure and all of that. So I think that we need also, funders also need to think about this in terms of how do we support community health workers more and shift from calling them volunteers. I really acknowledge the work they are doing in improving health at the community level. So we do work with community health workers as Nyanam, and we partner with them to help find widows in their households who maybe for one or two reasons are not able to seek care on time, or are not able to adhere to care because of multiple challenges they are going through, and have them have the community health workers support them. But we really need to think about this part of the health workforce intentionally, and think about formalizing and rewarding, reimbursing their contributions to the health of women, which is so tremendous in our settings in Africa.
Thank you so much. Rwanda has almost 50,000 community healthcare workers, but they are not yet on the formal structure as well. So that's a great one to invest in them. Nancy, last words.
Thank you. So for me, I will end by just saying data, data, data. Data is what will show us where we've come from, where we are, and where we intend to go. It paints the real picture of the actual situation when it comes to health, particularly women in health. Communities are not homogeneous. What could be working in Rwanda probably won't work in Kenya. So we can't keep replicating solutions and innovations across different communities. We need to go down to the actual targeted community and also involve them in the solution. The solution always comes from the target because they know best what is ailing them. You cannot ask a man what a woman needs in terms of health. The carrier of the problem is the holder of the solution as well. Thank you.
Thank you. Nothing for us without us. Huh? Yeah. Leah, over to you.
Thank you. I don't have much to say, but I'm very, very happy that I am seated with the philanthropists in the room. And for me, aside from everything that has been said in these forums and that will be said tomorrow, is Africa is, our roots are from oral narratives. But we still insist on these communities providing formal applications with digits, numbers, figures, presentations, PowerPoints, but they do not have access to all those. Why don't we reframe those applications or requests or whatever into stories? Because Africans are very good at telling stories, and stories don't lie. When you go to the community and you've heard a story, someone can verify if that is a lie or that is not. Let us change and make it more flexible for people to be more included and access these portals of money. And let us move away from the lottery mindset. You know, you apply and hold your breath that you get. Okay? We are looking for long-term strategic partnerships. Even people asking for funding, we are becoming very picky. We do not want project-based, activity-based, short-term-based funders. We want partners who are going to see us through the end to make change. Thank you.
Wow. Long-term strategic partnerships. Nadia, over to you.
You know, I've said a lot already, so I don't want to repeat, but I would just love for us to leave today, when we think about women's health priorities, that we would remember that availability is not access, and we have to think about what we are doing to address the barriers and the bottlenecks that keep women from accessing resources, from having agency, from making decisions that actually result in healthier, whole futures for themselves and their families. And then lastly, just as we talk about next steps, so that this is not just a convening where we've come together and networked and had great conversations, but if we're to put our money where our mouth is, I would love to see, and kind of looking forward to tomorrow, the conversation around equity and philanthropy. And just decolonizing a lot of the traditional relationships that exist in the funding partner relationship. Let's follow suit to what UNAIDS did this year, finally, for the first time, where they put out a commitment of X number of dollars to X number of communities by X year. We need to make that kind of a stand as a community to invest in women's health in the spaces and places where it's needed most. So that 10 years from now, we're not looking back and saying the same kind of alarming data sets that you shared in the morning. It should not be tolerable any longer that 70% of the world's global HIV burden is on this continent, as well as 50% of the world's population that does not have access to safe water. That should not be with the amount of money and resources that's being invested into the health space.
Thank you. Thank you so much. Please join me to give this wonderful panel and yourselves a round of applause. I think there have been very interesting insights that have been shared from the power of collaboration and coordination, involvement of the people that are involved, and not just tokenism, but actual involvement even in the decision-making and in deciding where the money goes. But of course, putting away all those rigorous and stubborn and whatever applications to actually making them easier for the communities to apply to, and really thinking about scale, and moving away from pilot syndrome. So thank you so much. This brings us to the end of our session, and we'll hand over back to the organizers for the next session. Thank you.
Thank you very much. Can we give them a big round of applause one more time?